Hi everyone, my name is Kazi Zain Hassan. I'm a medical doctor. I practice physical medicine and rehabilitation. Sorry, is this good? Everyone can hear me? Okay. This is my first time at this center. I've been invited to speak about ketamine. So ketamine now is the only legal psychedelic that we have available in Western medicine. I hope that's slowly changing. Psilocybin, MDMA, and other medicines are on their way towards legalization. But right now, we've been very fortunate to be able to use ketamine and induce transformative psychedelic experiences to help with a variety of illnesses. We've focused our efforts on depression, anxiety, addiction, PTSD. We also use ketamine to treat very difficult to treat types of chronic pain, so nerve pain, and then also a lot of degenerative types of pain as well. Okay? So we can hit next. Okay. So just disclosure, I am the medical director for a ketamine clinic here in Miami. The ketamine clinic is called My Ketamine Road. We can hit next. Okay. Sorry, I'm going to turn around. So just a few things about ketamine. So ketamine was first synthesized in 1964. It was tested in volunteers who experienced these very transient hallucinations and dreamlike states. At first they called it psychomimetic experiences that induce a psychotic-like phenotype. But what actually was happening is they're having psychedelic experiences. And ketamine was originally created as a safer anesthetic than phencyclidine. All right, we can hit next. In the 1970s, FDA approved ketamine for use in anesthesia for children, adults, and the elderly. And it's used routinely in the hospital for both anesthesia and procedural sedation. Next. So there's been a lot of safety studies on ketamine because it's been FDA approved for a long time now. And it's one of the drugs that we don't have any reservations about using in children. In fact, when children come into the emergency room for broken bones or any other kind of illness, and we have to give them mild sedation, we actually prefer ketamine because it has such a favorable response on the other parameters that we care about, including blood pressure, heart rate, and respiratory drive, as opposed to other anesthetics. Next. So it is a very effective anesthetic. The World Health Organization lists it as an essential medication in developing countries. We actually use it preferably in the battlefield for our military, because not only does it produce a very strong pain-relieving effect, but the people who get ketamine in the field after traumatic injury, as opposed to morphine, they have a much lower rate of post-traumatic stress disorder than the people who got morphine. Next. So it wasn't until 2000 that people formally investigated the use of ketamine as a treatment for depression. People noted that people had these lower rates of PTSD and noted a very strong, very rapid antidepressant effect as a routine of giving it in other settings. But then in 2000, a group of researchers tested to see if they could quantify what these antidepressant effects were. Next slide. Oh. Yeah. Yeah. Sorry, I don't know if that's my platform or not. the slide before, so this is one of the tools that we have to measure depression. It's the Hamilton Depression Rating Scale, and basically we're just looking here at the change from baseline in people who have severe depression. And one of the most interesting things about ketamine, as opposed to other antidepressants, is how quickly that it works. So if you can see the scale here is in minutes to then hours, so up to 3 days, from 0 minutes to 72 hours. And it's a strong antidepressant effect. So this is in contrast to traditional antidepressants like SSRIs, MAOIs, and TCAs, which they take a while to build up in the body and to produce an effect. So in psychiatry, the dogma is put patients on an antidepressant and assess after 6 weeks. So that's about 6 weeks before you can tell if that antidepressant is even working. A lot of people stop early because they kind of get frustrated that they don't feel anything, but we always try and encourage to continue to see if they're a responder. But the sad fact is that there was a massive trial called the STAR-D trial that tested the algorithm that we have to take patients through antidepressants, and up to a third of people over a 5-year span after taking 3 different classes of antidepressants never responded. And traditional antidepressants are just marginally better than placebo, but placebo can be quite real. So next. Okay. And this is another randomized controlled trial that's basically showing that ketamine is very effective in suicidal ideation, which is the biggest safety concern that we have in the medical field when someone presents with depression. You know, you can work through a lot of things, but when someone is suicidal, that's a medical emergency. And they've tested ketamine in the emergency room setting, because that's when people come in distress, a lot of times found attempting suicide. And this is one of the tools that we have in the emergency room that we can give right away that produces a strong antidepressant effect just to stabilize them until we can get them more help. Next slide. And this is that study. This is the data from that study. You can see the red line is the drop in depression symptoms. The green line there is midazolam. So the challenge with any study that is comparing ketamine or any other psychedelic to a placebo is that the idea that you're blinding the group to either psychedelic or placebo is almost impossible. You know if you got a psychedelic. It's hard to convince you that you did not get a psychedelic. So there's a lot of challenges around that. The FDA, of course, scientific community, obviously, we have to be able to test what's working and what's placebo, and it's very important to get good data, good quality studies. So this is a very real challenge in doing that type of experiment. One of the ways that we kind of get around that is we use what's called an active placebo. Active placebo means that it's psychoactive, but not in the psychedelic sense, maybe. Or people use a sub-threshold or low dose of the psychedelic to compare it with, because presumably you wouldn't experience that level of antidepressant effect if you didn't get the proper dose. There's an organization called MAPS. Has anyone heard of MAPS?
Yes.
Okay, great. It's an amazing organization started by Rick Doblin, who has dedicated his life to advancing psychedelics through the system. And now, because of his work largely, MDMA is already in phase 3 clinical trials, which just means that they're very far along the process, and maybe even 2 years away from even MDMA from being a treatment option for people with PTSD and other illnesses. And then so you see ketamine produces this effect over placebo, which in this case is midazolam, which is a benzodiazepine. So it feels like something's happening. It's definitely not psychedelic, but that it did help here. And then the people who failed the midazolam group, they were later then given ketamine. That's the orange line. And so you can see even in the people who, failed midazolam, when they were actually given ketamine, their rates of suicidal ideation dropped too. So this is a nice crossover design study. Next. Yeah, and so there's a lot of papers, in just clinical trials in the US that have investigated ketamine as an antidepressant. There's already over 4,000 patients enrolled in various trials looking at various protocols. They've also looked at anxiety, PTSD, OCD, a lot of eating disorders, and then there's a huge body of evidence on chronic pain. So it's a very different type of experience, but there's definitely a psychogenic component of pain. I don't feel like many people who deal with chronic, daily, severe pain, all of them are in some way suffering. So there's a mental component to pain as well. But ketamine's actions on pain is maybe at the spinal cord level where chronic pain transmission is. So it's very interesting. Next. Okay. So this is that study. This is 12 patients who were enrolled in that study, all had anxiety disorders. It's a very small study. And they were given doses of 0.25 milligrams per kilogram, 0.5 and 1 milligram per kilogram. So this is kind of important. The first study that I showed earlier, that study in 2000 kind of set the tone for what the current ketamine treatment protocol is, which is we do it by body weight. That's typical of all anesthetics. It's like you start with the patient's body weight, and you want to titrate the dose to effect. But what is the effect that we're titrating to, right? It's a psychedelic experience. Now, that's the view that some providers hold, including myself. But for other providers, they would look at the psychedelic effects, not as psychedelic, but psychomimetic, right? So that means that they want to, they're viewing that as an adverse event, or if we can get away with skipping the psychedelic part, maybe more people will tolerate it, and like they won't freak out. But that's because the people who typically give ketamine are anesthesiologists. So for anesthesiologists, they look at it through a very different lens than people who have experience with psychedelic medicine and the idea of set and setting and working through trauma through psychedelic experiences. So this is a dose-dependent effect. 0.25 is too small to produce that psychedelic effect. 0.5, I've seen about half of people have that typical psychedelic effect, and we'll talk more about that in a second. And then 1 milligram per kilogram is almost, you're going to have that effect, but of course a lot of things, including set and setting, have an effect on that as well. So next. Okay. Another paper here just showing intravenous ketamine for the treatment of chronic post-traumatic stress disorder. Next slide. So what is ketamine working on? So ketamine works primarily on the NMDA receptor. It's an NMDA receptor antagonist, which just means that it blocks that receptor. And what happens is you get an increase in glutamate signaling. In general, glutamate signaling is just the go signal in your brain. So you're driving increased neurotransmission. And one of the things that's released, actually on the next slide, is NMDA. It also has, BDNF. It also has action on a number of other receptors listed here. So, it's very hard to say exactly what the mechanism of action is, at least in the antidepressant realm, just by looking at the receptor activation. Next slide. So the effect of BDNF release, protein synthesis, synaptic strength, and synaptogenesis are shown here. So increased GABA transmission, just like any kind of learning, takes some repetitive stimulus. That repetitive stimulus has some effects on the cellular level, like literally everything that you know and all of your memory is physical changes to the microstructure of your brain. So that's the mechanism of all learning and memory. And so this is producing the chemical environment for that to happen. Next slide. This is a nice little tree showing dendrites, which are just the neuronal projections in the brain. And you can see after ketamine administration that dendritic tree gets a little bit thicker, and so you're enhancing neuroplasticity, so the basis of learning. Next. So these are really interesting studies, which this is a paper from Nature, Psychopharmacology, and this is showing the connectivity pattern in depression and how ketamine affects that. So how different brain regions are talking to each other during depression and then after treatment with ketamine. Next slide. So these are some pictures to kind of show what that looks like. So these areas that are active in depression or inactive in depression after a ketamine treatment, we know that ketamine is a very rapid-acting antidepressant. So by looking at this functional MRI data, we can kind of try to figure out what brain regions are involved and maybe see what other things we can do to affect these same brain regions and address depression the same way that ketamine does. Next slide. So the default mode network. Has anyone heard of this?
Yes.
Default mode network. Okay, yeah, great. So the default mode network is, it represents certain areas of the brain that are involved in, they're more active when you're resting, when you're daydreaming, not engaged in tasks, when your mind is wandering. And a wandering mind can be a dangerous mind if you're depressed. It kind of lends itself to rumination and very depressive patterns of thinking. And so the default mode network areas, which are midline cortical structures in the brain, they're more active in states of depression. And there's very interesting things that happen. So ketamine temporarily disrupts the default mode network activity and the relationship of the default mode network to other nodes of the brain. So this could be another potential way that ketamine is working. Next slide. So the thing that I find very fascinating is the overlap between mental health disorders, or what we term or group or categorize as mental health disorders, versus just normal suffering, I guess. And then the default mode network, which is representative of who we are as people. Like the default mode network is active when you are considering yourself or projecting a self-image. It's your internal world. And then with meditation has they're very different types of meditation, but meditation has been linked with diminishing the default mode network and kind of engaging in the outside world and taking in the stimulus of what's happening in the present moment. And that's almost like a mechanism of how people might feel more peaceful because they're not ruminating so much in their internal suffering. So I feel like there's a lot of overlap between meditation, psychedelics, and well-being, mental well-being. Next slide. This is this is the default mode network, and you can see, or just there's changes that happen with meditation. I think on the next slide. So there's very obvious things that you can see that happen in the brain, active areas that are quieted with default mode, meditation, and these changes actually persist even when you're not meditating. So in practice meditators, you do have this hypoactivation of certain brain regions that are, like when you meditate, they go up a lot, but even when you're resting, that you've kind of like conditioned your brain to relax. Next slide. Okay, so yeah, I get a question. I get asked a lot: is ketamine a psychedelic? It is absolutely a psychedelic, and so it's definitely dose dependent. But here, I really like this because this is showing a lot of the dimensions of a psychedelic state from the what you see in terms of your perception. So the imagery, the audio, visual, synesthesia, like the blending of senses, the changed meaning of precepts, and some of these things are the big ones that I really care about, which are the insightfulness, the experience of unity, spiritual experience, and then ketamine. Ketamine is that orange line there. The other lines on there are LSD in dark blue and psilocybin in light blue, and then MDMA is the yellow. So there's a lot of overlap in the types of experiences that people have with ketamine and other psychedelics. Okay, next slide. So this is, there were some researchers who, as difficult as it is to characterize different psychedelic states, they tried to do exactly that, and they called them non-ordinary states of consciousness. And so people have done this with ketamine. So there's, and it's kind of like a scale with the lowest level being the empathogenic experience. So I'll just actually read a little bit of this. So this is awareness of your body, comfort and relaxation, reduced ego defenses, empathy, compassion, warmth, love and peace, euphoria. The mind is dreamy with non-specific color visual effects. So this is typically what happens at a very low or sub-psychedelic dose of ketamine. Then you have an out-of-body experience. So this is a complete separation from one's body, significantly diminished ego defenses, visits to mythological realms of consciousness, encounters with non-terrestrial beings, emotionally intense visions. You might see deceased relatives or spirits, vivid dreams of past and future incarnations, and then re-experiencing of the birth process. And this is definitely what the subjective experience is like with ketamine. So a lot of people share this with a lot of other psychedelics. People derive meaning from these experiences. It can represent very abstract ideas in their mind. Ketamine, along with other psychedelic states, a lot of your emotions and tensions and trauma are not just logically stored, in the left side of your brain that, you and I can just talk through. A lot of it is stored in the emotional centers and kind of like abstract, and talk therapy has its limits, even though we think it's very important, which I'll get to. Next. Now, these are two of the more significant non-ordinary states of consciousness. So there's the near-death experience, which is a departure from one's body, complete ego dissolution, the loss of identity, experienced physical and psychological death, experience being a single point of consciousness simply aware of itself, which is something that you get with meditation. reliving one's life aware of how actions have affected others with moral judgment of oneself. And then there's the ego-dissolving transcendental experience. So this is an ecstatic state of the dissolution of boundaries between the self and external reality, complete dissolution of one's body and self, transcending normal mass, time and space continuum, collective consciousness, unity with nature and the universe, and sacredness. Next slide. So side effects and contraindications. So this is obviously very important. This is one of the things that I always screen for before anyone goes through a ketamine experience. So next slide. So some of the side effects is something called an emergence phenomenon, which is when people come out of a ketamine experience. People can be agitated. Now, this is not something you typically see in a cycle or in a therapeutic setting. This is more when people get it in a trauma setting, in the emergency room, in a hospital, under fluorescent lights. Like, this is a very different area. That's where most of ketamine is given. So a lot of these percentages of side effects come from that. And just so that we all understand what doses we're talking about, the amount of ketamine that we give in the clinic to produce these very profound psychedelic experiences is about 0.5 milligrams per kilogram as a starting dose. That's anywhere from 50 to 100 milligrams delivered intravenously. And that's under slow continuous infusion. So that's about an hour of an experience. People rapidly metabolize it and then rapidly excrete it, so you're kind of back to normal in half an hour after the infusion ends. You would give the same amount that we give an adult over an hour to a child half the size in 1 minute in the emergency room as a push. So that's just kind of like relative dosing, so you have an idea. Other things, laryngospasm, but that's extremely rare. That's only in head and neck surgery cases, so it's not even worth putting. But agitation, like I said, nausea, vomiting, which can be medicated with Zofran pretty effectively. Elevated blood pressure and pulse. This is the one thing that I'm very strict about, is that if people have uncontrolled high blood pressure, it's a pretty strong contraindication, or if they have any heart or liver issues. So valvular heart disease or history of heart attack, that's something that they may not be the best candidate, even if it's low dose. Next. Next slide, please. So ketamine abuse. The other thing I get asked a lot is it legal? Yes. It's legal under medical supervision in a clinical setting. And then the other thing is, isn't it horse tranquilizer or special K? So just like we use antibiotics and hundreds of other drugs in both animals and humans. Ketamine is the same. It's also a human tranquilizer. And yes, it is used illicitly, like many other medications are. But there's a way to be treated with ketamine in a monitored clinical setting, and to make sure that you have a pure experience, rather. So next slide. Okay. This is the active lethal dose ratio and dependence potential for ketamine. Just to give you an example, LSD and psilocybin on the bottom left are very, very safe and very, very, it's impossible to OD on them. Ketamine, we use it at extremely low doses, so it basically would fall like in that bottom left quadrant at the doses that we give. And then the dependence potential is a little bit higher, but if you look potentials, alcohol obviously has a pretty high, or rather on the scale, moderate dependence potential. and then morphine and heroin are there at the top. People do abuse ketamine. There are other countries that where ketamine is more easily obtained, and so there's like a lot of teenagers using ketamine and other substances together. Definitely possible to have a bad trip when you're kind of doing it in an uncontrolled setting. Other stressors going on or other external factors can influence ketamine just like any other psychedelic. Next slide. So who shouldn't get ketamine? We went over this a little bit. Uncontrolled high blood pressure, unstable heart disease, active substance abuse. We do use it in substance abuse, but it's kind of a relative contraindication. If someone is really ready to make that commitment to stop using medication, ketamine was originally used very effectively for alcohol abuse, and so that's something that we've effectively treated cocaine abuse with it and other types of dependence. Next slide. So this is just the biopsychosocial spiritual model of mental health. So yes, at the core, there's the biology that's involved, and but biology, if looking at mental health issues just through the lens of biology is very limiting. The idea that SSRIs are fixing a chemical imbalance in your brain has been debunked. It's not even clear that SSRIs do what the name says they do, the serotonin reuptake inhibitor. So a large part of it is placebo, and that's just from the placebo-controlled studies comparing SSRI. There is still, on top of that, a benefit. So where does that benefit come from? A lot of it is off-target effects. So that means that it's not hitting the serotonin receptor and blocking reuptake. It's the other random effects that we don't know are happening, are producing that effect. And maybe we don't need to know, but that's an interesting question. So more importantly is the psychology of it, your awareness of your consciousness, your unconscious, and life experience. What are your behaviors? What are your relationships with friends and family? How much community do you have, and how much social support do you have? And then spiritual. And spiritual doesn't have to mean religious. It can be just a relationship that transcends the human body. Next slide. So ketamine protocol. So ketamine is most effectively delivered IV as a slow continuous infusion. The starting point is 0.5 milligrams per kilogram, but of course that's a starting point, and for us, though, our outcome is essentially for you to have that time in between to have some integration. There's something about that number that people make these very significant changes. Some people they feel extremely different after the first infusion. But for some people, and this is more common in the people who have had severe depression or anxiety for a long time, may not feel anything until the fourth or fifth. But we see a 70 to 80% responder rate. So it's very, very significant. And it's not covered by insurance at this time, unfortunately. Next slide. So in conclusion, ketamine is a safe and legal medicine. It's been used for over 50 years. It's an NMDA receptor antagonist, and it increases BDNF and helps with neuroplasticity. It has effects on the default mode network activation, which shares similarities in meditative practice. It can be rapidly effective in the treatment-resistant depression. Treatment-resistant depression meaning that you failed 2 antidepressants for an adequate period of time. So some of the limitations are the long-term studies are still in progress because there's been more interest around it. The American Psychiatric Association and Cleveland Clinic have called it the biggest breakthrough in psychiatry in over 40 years. So this is definitely something that's getting a lot of attention now. And then ketamine, we've seen it, ketamine can play a very powerful role in transformation, and it's only part of the solution. I feel like the integration, which is the processing and the counseling and the support that happens afterward, to help you interpret and to expand on what the content of your experience was, is just as important as the experience itself. Because we're not interested in just the state of mind as you're having an experience. We care about the personality traits and the character that you have out in the community. Next. So again, this is our ketamine clinic. Next slide. So this is just where you would do the ketamine infusion. Next slide. Yeah. So if you can find like a natural environment, more of like a somewhere you can kind of walk in and you can feel at home and feel safe. That's ideally the setting in which you'd want to do it. We try and do a few things to help with the mental framework, including some preparation, which is setting an intention, doing some meditation before the infusion, because the content of your mind before you start your infusion has a lot to do with the experience that you have. All right, next slide. That's it. Any questions?
Yes. Yeah.
Yes, hi.
You got any kidding? No. My neighbor, ironically enough, came over this morning. My neighbor came over this morning to give my daughter a Christmas present. She's a neuropsychologist, I want to say, for the University of Miami. She's, I want to say, late 50s. And I tried to broach this subject to her today because it seemed like it would be something she should know about and possibly be interested in. And my impression was that it's maybe just such a loaded topic, or just the idea that we would use a drug that has the potential for abuse and recreational use and all that stuff. Like, it just seems like to them, it's almost like an okay boomer moment when I was listening to her respond. Like, why the resistance to that? And do you think that it obviously, I think you would agree it's harder to convert the older generation of PhDs and doctors in this country, that there's some merit to this. And is there a 30-second, what advice would you give to someone who wants to try and get that over to somebody quickly, that they should at least be open-minded about it, even though they've been training for decades to stay away from stuff like this?
That's a great question. So why the resistance to it? I don't have a great answer for why there would be so much resistance, because typically when you're making the way they're trained to make medical decisions, basically you're looking at the benefit to harm ratio. And my suggestion would be just to have that person who's maybe practiced in a way where, at the time of their training, we are so, medical culture here is so hierarchical. So you are learning from, you're basically like shadowing people like in the hospital system, and you take on their patterns, and you're taught to keep up to date on certain areas of research. But realistically, in your wheelhouse, you may not read journals that don't have to do with your field of medicine. So a lot of the ketamine papers, they came out in anesthesia journals, and then when you're conducting an anesthesia trial, you are looking at the effects of ketamine as a side effect. But what's been so positive recently is all of the major psychiatric journals, the most high impact factor journals, they're all touting the benefits of ketamine. And so all I would say to someone who is in the profession of psychology, psychiatry, mental health, is just for them to look at the research on their own, critically and with an open mind. Yes?
questions for you. One of the first ones is you mentioned that it's synthesized. What is it synthesized from? Is it from a plant, from a crystal? Where does it actually come from? You may ask both questions. And then the second question, you mentioned integration, which I think is very important with psychedelics, especially for people that are starting off. What are some of the protocols or some of the things that you do to help these patients that may have never had a psychedelic experience integrate those experiences? Thank you.
Another great question. So the first, I don't have a great answer. It's a synthetic chemical. So it was derived as a alternative to phencyclidine. So it shares